Welcome, everyone. Fantastic to have you on today's webinar on cartilage injuries of the ankle, a topic far more richer than we usually think. I started working on ankle injury prevention more than 2 decades ago, and somewhere along that journey, I met Pieter D'Hooghe and Gino Kerkhoffs, and it's a real pleasure to now bring them together in this webinar. And back then, we thought we understood everything about ankle injuries. But the more we learned, the clearer it became there is no such thing as a simple ankle sprain or a simple ankle injury. And I believe today's topic, cartilage injury, is one of those areas where that complexity truly starts to show. So thank you, Pieter and Gino, for joining us. Also, a big thank you to our co-hosting partners, European football clubs, for supporting this session, as usual. So as said, two talks lined up. Gino will start us off, I believe, followed by Pieter. And then we will open the floor for proper Q&A with plenty of time to dive into all of your questions. So please post them in the chat as usual. Before we get going, let us know in the chat where you're joining from. And throughout the webinar, feel free, as said, to post your questions there. We're watching closely and we will try to answer all of them, or at least as many as we can later on. So let's get started. So I'll give the floor to Gino first. Welcome, Gino. Really cool to be working on this side. I used to be with you in Amsterdam. You have snatched me away, so it must be lonely there for you. But glad we still can work together on topics like this. So I'll pop your slides up here, and then there you are. And then the screen is yours for the next 10, 15 minutes.
Thank you. Thank you very much. Thanks to you, Everett and Kat and UEFA for allowing my Belgian brother and me to reunite here on the screen. So let's kick off. Thanks to the team in Amsterdam for helping me out the last 15 years in this ankle cartilage journey. You already mentioned that there's really no such thing as a simple lateral ankle sprain. I think all the way back to 2015 and 16, we came with this editorial that made this first statement. Thereafter, we connected the osteochondral lesions of the talus to this not so very simple sprains and fractures. And then if you look at images like this, you can imagine that this could kick off a cascade, something we also got down on paper together with Jari and Jon Carlsen. So today probably we'll focus a little bit more on the early cracks and osteochondral lesions, and then in the osteochondral lesions I will hand the word to Pieter, and then we'll do discussion together. So what happens at the beginning stages? There's lots of sprains and fractures and small moments, bigger moments, giving way moments, and we emphasize that these moments all give these invisible cracks, and that this is not just a hunch, that something that our resident and PhD student Ron de Blom developed in the lab, a model where we dropped the weight, something similar to a giving way moment on the pitch, even a simple giving way moment, not even a sprain. And we saw that although on micro CT scan we could not show any osteochondral damage, we could show at cellular level that the whole joint biomechanics altered after the application of even a simple axial impact load. So that kind of changed the whole idea of okay, how to do a fast recovery and how to not protect the cartilage, because we see that in 3 to 12 months after trauma, this painful stiffness and deep ankle pain, cartilage and subchondral damage already develop. And then later on we get to the end stage of osteoarthritis. So this would be such a typical case of a young elite football player, male, 70-year, complains about some ankle pain 5 months ago, and then enters our patient clinic 5 months later with deep ankle pain, and then the cascade would be, okay, a sprain. Physiotherapist of the club says, hey, you can return. I'll just tape you. Player wants to play himself, obviously. We just got the pick in the team, so he wants to stay at the team, tries to play, then goes down from 90 minutes to 60 minutes to 45 minutes, and then goes down in training from 5 times a week to 2 times a week, and then 2 days of pain. And then after 5 months, only 5 months, he enters and shows a CT scan like this. So this would be this typical case that we recognize. So deep ankle pain, recognizable palpation pain, mostly on the medial side of the talar dome with the foot and plantar flexion. Typical that people said is a locking system syndrome or deep ankle pain. And that we got into the Amsterdam Ankle Cartilage database with over 2,000 patients at the moment, of which they receive different treatments. About 20% has concomitant injuries noted, like instability or alignment problems. And that made us come up with a kind of a simple flow chart. We published in Foot and Ankle Clinics, the first version. And what you can see here is for athletes as well as football players, the BMI will not be an issue. But then the instability and the alignment will be an issue. And you can see that this is really at the top of this list. So always before you start thinking of all these nice ankle cartilage treatments that are listed in here, first check alignment and first check ligamentous instability, because if you have a gross ligamentous instability that ends up in giving way problems every week, any cartilage treatment will fail in the end. So that will be one of the messages for today. So then we go out a little bit back to the bottom and we see fixable fragments, we go for fixation, and this technique will I'll just list the fixation and the topic as 2 different treatments that you could do in athletes in bigger lesions. So first, the lift drill fill fix. So this originates from interarticular non-union treatment, which and also condylitis dissecans as well as a fixable fragment. You should fix if it's symptomatic. So obvious advantages is cheap technique. You preserve your hyaline cartilage, you preserve your talar congruency, and you have a very good filling of the subcondylar bone. So if we go over this quickly, it's an arthroscopic as well as an open technique. You see the anteromedial distal tibial corner and the talus with some slight soft tissue distraction. You see the Dunscombe draw, typical of a loose fragment underneath the cartilage. You can cut the cartilage and lift it, then debride it on both sides, both on the fragment side as on the talar side, and then fill it up with some cancellous bone either from the distal tibia or from the crest, make a sandwich plasty, and then give good compression and rotational stability. So we published quite a lot of papers on this, and even after long-term follow-up, we see that the subcondylar bone plate feels much better than after BMS and BMS with orthobiological treatment. So this fixation treatment is the first gold standard. So if it's fixable, always fix. Even you see at 7 years, there's less of 5% of revision cases. So it's a good, solid technique that's not too expensive. Then the other one to pitch is the transosseous periostic iliac crest graft, which is a press-fed iliac crest graft. You can see it for the bigger lesions where BMS or orthobiologicals will not help anymore. So what we do there is get our axis sometimes on the medial side with an osteotomy, take out the damaged cartilage, do a subcondylar bone filling. This is the drilling. Then we take a small piece from the middle of the crest, so there's no problems there. Oversize 1 millimeter and then do a press fit graft that looks like this. And you see that this will also make a very solid treatment for athletes as well. So cast immobilization started with 6 for non-weight bearing 6. Weight bearing now we're down to 3 versus 3. And we see that's enough. 100% consolidation after 6 weeks, all on CT scan. So people want to read about this, the medial, both on the lateral technique that are quite different because on the lateral side we don't use an osteotomy, and both the 2-year and very quickly also the 5-year results published in the American Journal of Bone and Joint Surgery. So back to our patient. Is a male athlete, 17 years of age. This was his pre-op CT scan, mind you, after only 5 months after the first ankle sprain. So a cystic crater-like lesion, which is quite big. So we did a medial topic. This is the 1-year post-op CT scan with a full return to performance and 3 times training a week at 1 year. And then after 5 years, fully return to a professional team. If you look at the CT scan critically, you see that the graft is really very nicely incorporated, but you can also see that there's already some osteoarthritic process. So this would make a good handover to Pieter. First, give you some take-to-work messages like choose the treatment based on patient and lesion characteristics, like we showed in the list and in the workflow. Then always address ankle instability, both in prevention and treatment of the OCLs. And LDFF and topic both are good techniques. So it's fun working in Amsterdam, so a great place to work. Welcome to visit. And ankle cartilage lesions can be treated successfully also in elite football. So I'll hand over to my Belgian brother. Thank you.
Thank you, Gino. Quick overview of all the work you're doing in Amsterdam. Great that this was set up a couple of years ago, and also good to see this expanding tremendously, I might say. The group is very large now. So kudos to you and the team there. You really dug into a niche that needs to be studied, I guess, for the future benefit of players. And I think that's a good link to Pieter, who will join us now. So I'll say goodbye to you for a few minutes, Gino, and see you back in a bit. Because Pieter will connect us, I believe, on the more long-term consequences of these injuries. So Pieter,
it's a great lead out. Thank you, Gino.
There you go.
And Kat, do you have my slides?
Yep, they're up. You can talk.
So thank you. First of all, I confirm that it's fun working in Amsterdam. It actually changed my life, so I couldn't be more grateful. With that, we have the pleasure of joining from the acute lesion and the ankle sprain towards cartilage cascade, as you've heard so eloquently, towards what's going on later onwards. And I've called it the footballer's ankle on the edge. So I have no disclosure to this talk, but we're going to talk about the talocrural joint and the football-related cascade of ankle sprain towards cartilage and then early osteoarthritis. As said before, but important to state and to confirm, is that the ankle is not the knee. Most research on cartilage is around the knee, and we know that the knee is an incongruent joint where you need menisci to keep things together, and the cartilage has about 6-7 centimeters, where in the ankle it's a congruent joint where you only have 2 millimeter cartilage. So you have to look at it from a different perspective. And the moment you have these cracks, as mentioned, you get the pressure in the nociceptors of the subchondral plate, and the whole cascade starts. And you can actually see it on the left side here, that there starts to get fibrillation over that little layer, and that's the sign to be careful and to watch out for the future and look at options. So when we look at the world of elite football, most of the problems are ligamentous, but the cartilage is number 2, as you can see here on the yellow arrow. So it's linked to ligament instability, but it's also an entity on itself. So the very few conditions in football have gone to the table of the decision makers to make sure that we protect our athletes. And 2 of them over the last 2 decades were the elbow kick and the tackle from behind, as you have seen, for example, in the Bayern Munich game. And nowadays, for these bad ankle sprains, we actually get a red card. And there's a reason for that, because it's the start of a potential career-ending cascade in the athlete, as you have heard before. And it's important to mention that in the world of football. Now, recently, Matthew Buchtorp, Evert, and a multidisciplinary team have looked into that, because when we want to understand something, we've learned that the best way is to look at it from the start as a systematic video analysis of these sprains. And in these type of players, we actually learn a lot. And what do we learn? We learn that you have a lot of ankle injuries actually that are osteochondral and chondral. So you have to see them in both ways, and we'll go back to the rest in the future. But basically what we see in these ankle sprains is that the cartilage is big time at risk, much more than we used to know in the past. And there's not only a reason of contact or of impact or injury from it, but it's also a reason that has intrinsic and extrinsic factors. Intrinsic factors are mainly the alignment and the stability. And when you look at stability, I wanted to share this video. It's not for the sensitive viewers, but basically, while we are in the lab, we can look into how things move. And here we do a full inversion sprain. And as you can see, the alignment is fine. But the moment you get into a specific instability, you have these shear forces from that lateral talar dome going into the joint. And then you can see there's actually a cartilage lesion just created because of that. So malalignment and instability are primary players in that game. And when you do MRIs on all ankle sprains, you see a lot of things, but you see mainly that the cartilage is already affected by these cracks. And repetitive instabilities lead to some initial cartilage problems, as you can see here on the right T2 MRI. And once you see that, you know you have to do something, because the number one is the instability, the number two is the cascade toward the cartilage, the number three is that all your restraints fail and you get problematic situation. So when we look at some data, and you look at ankle osteoarthritis and its association with severe ankle injuries, you see that in football, for example, 9.2% of players who just retired have ankle osteoarthritis, and that's 4.6% in rugby. But the most predominant finding of Gino, his group, is that following every injury and or surgery, it gets worse. So when you look at injuries like that and you see a varus instability, and you see a progressive collapse of the cartilage and actually collapse of the whole joint, you know that this has started with a cascade, and that is now an end stage because of that. So playing football per definition is not a reason to have osteoarthritis, but recurrent instability, sprains and impacts on it that are not treated or treated regularly in conservative or surgical fashion actually start the cascade, and that's where it goes more wrong. So that's an interesting finding so far for the ankle sprain. But you also have problems with the so-called high ankle sprain. It doesn't always have to be in contact. We won't go into detail into it, but we have to know that where we know that chronic lateral instability leads to cascade of cartilage problems, we actually see the same happening in syndesmosis. And that's important to know, because up to 20% of cartilage injuries occur in syndesmosis instability. So look for it, because it's there in many cases. And then, of course, you have the bad tackles in football, where you have the whole plethora of problems with fractures, with deltoid ruptures, with syndesmotic instability, but especially look for the cartilage, because bone, ligaments, and tendons we can heal with regenerative potential. Cartilage is still a problem child in that perspective, as you have heard. And why do I say that? Because it's our job not only to fix bone, but also to understand the mechanism of injury, as you have seen here, where we see that a fracture has been treated well, but the syndesmotic instability not. And there's a massive, fast progressing cascade of cartilage problems that are career ending. So it looks at us, but we have to look at it as well in order to avoid that we get these type of patients still in clinic with disastrous problems that could have been avoided over the cartilage. Now back to the surrounding problems, because we talked about the cartilage, but we also see that the synovitis, the impingements, and the osteophytes, they create cartilage problems. Like here you can see a lateral CT scan of an anterior bony impingement, where you have these enterophytes really affecting the cartilage from the front. And when you look at them, you can have talar beaks, you can have tibial plafond beaks, but basically if you look at it from the inside, you see on the left proper cartilage and on the right side bone. That means that these impingement spurs, they really rail like train rails into the cartilage, and we need to identify them on time in order to make sure it doesn't come to that type of stage. And you don't always need a mechanical conflict. You can see it in the joint as well, with massive red inflammation that actually degrades the cartilage and creates a biosphere of problems where the cartilage chondrocytes really suffer from. And not just that, you also have these loose bodies that are part of the cartilaginous problem and can actually affect the mechanical conflicts and make it worse, because you have to look for them, and they can be pretty spectacular in size sometimes. So far for that. But when we look at cartilage and how we look at it, every treatment has an increased return to play. So you have palliative treatments, reparative, substitute, and regenerative. It's quite technical. We won't go into much detail, but nowadays for the complex, larger OCDs, you saw that you can take the pelvic graft, which clearly works very well, but you can also look into other biological systems like combining the minced cartilage with the stem cells and the BMAC. In combination with scaffolds, there's pretty interesting new data on that, where we now see that in the past, the disadvantage was that we had to take the cells and then 6 weeks later do another surgery, where now we can do it in one step. And you have to look at it from a more complex point of view. It's not just a cartilage lesion. You have to look at the scaffolds, the biological components, the surgical steps, and especially also the regulatory complexity. As Gino said, some things are just too expensive to do on a regular basis. So there are treatments nowadays in the algorithm. What we see is look for the size, the location, and the bone marrow, because they define the strategy, the approach, and the severity. And then look into the timing of the season and also the proper techniques for the more complex or larger injuries. Now, I've put this slide because I'm still fascinated about this field. I don't understand it very well, but what I see, for example, is when you look at the adipose-derived mesenchymal stem cell therapies we do, on the right side, you see an MRI of a football player with a lot of edema, pain, cartilage problems. And on the left side, you see after 2 months of stem cell injections, where you clearly see that there's a bit more breadth to that footage, a bit more, call it less subchondral pain, and that clearly extrapolates into the clinical setting as well, with the player feeling much better. So I truly believe that osteoarthritis is a mechanical conflict, is a mechanical problem that you have to address through stability and alignment. But still the cells show that there's an inflammatory component to it that we control with that. Now, we can't talk about early osteoarthritis in the ankle after ankle injuries without mentioning one of our total heroes, Marco van Basten, who actually had to sadly stop way too early and couldn't shine anymore on the field and show us his skills because of that. So when you look at the long-term consequences, in the knee, there's a massive amount of data. In the ankle, there's hardly anything. And they're all pretty old papers. So we have a lot of work to do. But I found a few that I want to share with you. Now, when you look at UK retired soccer players in a cohort of about 900 adults, we basically see that there's very little robust evidence to say that soccer leads to osteoarthritis. When you look at the sports participation after an arthrodesis, for example, there's a satisfactory functional outcome and pain reduction with a slight diminished sports participation. So people can still be active. We're not talking about the elite world of football now, obviously. And then the comparison with total ankle replacements, where you see that people have actually more activity profiling than before the surgery. A systematic review shows that what the current literature does not allow to advise TAA for young and active patients who want to play sports. But in selected patients, they can remain active. So it's all a little bit, but not very spectacular. And if you then compare the arthroplasty versus arthrodesis, there are basically no significant differences between the two groups. So you get a bit more active, but you were inactive because of pain and stiffness. So that's not a big worth mentioning. But when you compare both, they both give you a bit of more activity, but nothing really spectacular. So in summary, early osteoarthritis in football sees you, but we have to make sure we see it at first and we see it earlier so we can avoid the further cascade as mentioned by Gino. In football, we emphasize the collaboration, the fact that we don't just fix the injury, but we look at return to an elite level. and taking into account unique players' core objectives. You can read a bit more on it if you want in these latest textbooks. And with that, I go back to you, Kat and Evert.
Thank you, Pieter. Let's go for a little Q&A. I got some questions lined up for you as well, so be prepared. I sharpened my pencils. And while I fire off some questions at Pieter and Gino, feel free to add any of your questions in the comments or in the chat. We'll pick them up and we will weave them into our discussion here. To start off, Pieter and Gino, it's like almost like a dark image of what can be if we don't treat ankle injuries well. So maybe a first question would be, when a player presents with a simple ankle sprain, simple, what are any early signs that should make any sports physician or football doctor suspect a deeper cartilage involvement? You're muted, Gino, so you need to click a button somewhere.
Yeah, better. So I'll ask Pete, actually, you want me to kick off, Pieter, and then you take over? Okay, perfect. So I think, so there's two different things. I suppose there's a lot of club doctors and physiotherapists also in here. So it's a little bit different from consultancy like Pete and me or being on the pitch. So I would say the thought is that not every sprain needs to go to the orthopedic consultant. So, good question from Evert. I would say first, get your trauma mechanism right. Get your speed right, your velocity, and see what damage can be done. See if it's the first time inversion sprain, or it's the second time, or it's the 12th time. See how the ankle reacts after a few days. See how the ankle is stabilized by tape. And also take care that you are not mixing up syndesmotic sprains with inversion sprains. So these would be first alignments on the pitch. And then if they come to our office, then it's most of the time it's already quite late, So then I would say get apart the syndesmotic injuries from the lateral injuries. Try to make the lateral laxity objective, and then look for concomitant injuries, both judging from the trauma mechanism as well as from your physical, as well as an MRI can be useful. But leave it to Pete to not make my answer too long,
So Pieter, want to jump in?
Yeah, sure. And I think you hit it on the spot. I mean, the last thing we want is to say that every ankle sprain needs that full assessment. However, we have to take the detail out of it. And once you have that red flag, that's where we have to be aware. So maybe to top on that, for me in clinic, some intra-articular swelling and mechanical symptoms ring a bell. That's something I really want, address as well on top of what's been mentioned. And then, of course, the alignment and the instability as mentioned. But you have to know that a dynamic assessment can be done immediately. If you have that, for example, a deltoid ligament tear where you have that real collapse and the secondary restraints are already at risk, that's something where you're like, okay, this might evolve to bigger problems. So that's basically something maybe to add to that. But as Gino said, this is the way forward.
Yeah, I think for the initial assessment, like Pieter said, we can add, so I suppose, a few tests, like a circular tape test for the syndesmotic injuries, if it makes a huge difference with dorsal flexion, extra rotation in a weight-bearing, one like weight-bearing situation, that would be really pointing at a syndesmotic problem that is potentially to prevent chronic laxity. The medial assessment as with the medial collapse, and then lateral laxity. That is, if a player does not show any balance in the one-leg stance, then that would also be, like keeping towards this is too much. Just some simple tests.
And maybe a clinical pearl, if it could be as well for the viewers today, is that if you have a player saying, over the last 5 years, I had two sprains a year. I mean, that's not weird in football, right? But if he says, can you have a look, because I have some deep pain here, well, that's where you really want to listen carefully and do some added imaging. For me, deep pain is a major red flag.
Yeah, exactly. That's a good
So
point.
now,
I think.
in your answers, you already have 3 hooks for questions that are in the chat. So let me start with the first one. You talked about red flags, and the first question that popped up in the chat is whether capitation clinically is a reliable sign of cartilage injury. Is that one of the red flags to be looking for?
I think, crepitations in the joint can be a tell sign. I would go for the deep ankle pain and the locking symptoms first, and then crepitations, they can also arise from tendons and from some capsular swelling, and maybe even from some osteophytes, cracking. So I think crepitation is a little bit lower on the list for me than the deep ankle pain, and also the pain when starting the exercise, when starting a match, and then if they're able to play through, and then with big swelling afterwards, that in combination with Pieter mentioning the deep ankle pain would be a little bit higher up in the list, I would say. But it for sure, locking and crepitations are also a possible tell sign.
Okay, good. That links me then maybe, no, there was another question being asked about syndesmotic injuries. You just mentioned it as well in your answer. So maybe this one's for Pieter. We had a previous webinar on the whole topic, but maybe Pieter, you can briefly answer on this.
Absolutely. How much time you give me, Evert?
Yeah, take a minute or two.
So basically, when you think about a syndesmotic injury, don't do it in the stadium the same day. You won't see it. You get the swelling down, and then you basically want to know if it's going to be stable or not. So most of the time you will see grade 2s, where you have a grade A who's stable, grade B who's unstable. How is your workup? After, let's say, 2-3 days, you get the swelling down. If you have a combined medial pain, if you have a combined radiation up from distal lateral till 45 centimeters upwards, and you have a positive squeeze or external rotation test, these are actually 3 evidence-based signs. I wouldn't say pathognomonic, but pretty close to be aware that there might be something more going on. And I think that might be a helpful triad to check. There's more to it, and of course we have more and more the non-invasive approaches. And maybe I don't want to steal the fun here, but one of Gino, his fellows, Noortje Hagemeyer, will defend a thesis on the 5th of December, where she has absolutely hit the spot, in my personal opinion. And congrats and kudos to you and the team, Gino, because I think that's going to be a game changer for diagnostic testing in syndesmosis for the future. And we will all benefit from that. So all go to the Agnieten Kapel on 5th of December.
There's a few tickets left.
Thank you. Thank you, Pieter, for that answer. And another question in the chat. You're all talking about he when we talk about cartilage injuries. And one question is if there's a difference in how these cartilage injuries develop between male and female players, which I think is an honest question to ask, because most evidence we have is probably on male players. But what is your experience here?
I can answer from the database a little bit, from that size, because it's not a 50-50, but it's a 55-45. And Ariana Giannakos from the States, she's looking into the male-female differences, both in the athlete and non-athlete population. So we didn't really cut football players from the rest of the athletes, but we did not find any difference yet, not in the pattern, not in the lesion characteristics, and not in the rehab times, and also not in if different treatments would fit female better than male. Actually, we did not find any difference yet between male and female. So we're on it. We're on the subject, but so far it seems that the ankles can be treated alike.
An ankle is an ankle. That's basically
would be another
what you're
statement
finding
write
so
an
far.
editorial about. No?
Yeah, okay.
Well, as you know, I also have a personal interest in female football, and when you look at the cartilage, we see what we see. But what we do see is that in the intrinsic factors, there's much more ankle sprains in female players. So that doesn't extrapolate to cartilage lesions, apparently, which is great news. But it is an instigator for problems. So it is something to really tackle from the beginning in female football.
Then, being a bit devil's advocate here, we don't see any differences in your database, Gino, but let's be honest, that's highest quality care for the people that come in. If the resources between male and female clubs are not equally distributed and the quality of care may differ between both, would that have a significant impact on the potential outcome?
Yeah, I think, from the iceberg principle, you make a very good point there. So we probably see the top of the iceberg when it comes to female football at the moment. It's getting better also after the ACL study, obviously, that we're working on. And I do feel that also in ligamentous laxity, there's a difference between male and female. It seems then, having said that it might be that the female cartilage is able to protect itself a little bit better. So it might be that the subchondral bone cracks heal faster in female than in male. And that would be a possible explanation for having the same incidence. Because that is what seems to be the case, that there's not a higher incidence in the female football players. If we look at all the MRIs, for example, at the local club from the screenings, then we don't find more cartilage problems over there.
Okay.
But then a very interesting subject was, suppose, prevention and treatment, like we found each other once, like in preventive measures are also secondary preventive measures after a treatment. So I think there's a world lying open there for especially female players.
Okay, good. Thank you for that. There's one more question, not directly linked at cartilage injuries, I presume, but maybe there's a link to be made if you can answer this one. The best method for treating a traumatic talus edema.
Very simple, unload.
Voila.
You can put PEMF on it, magnetic wires. You can put shockwave on it. You can put inlays to reduce the load. You can even now do intraosseous stem cell therapies. I've seen things fly all over the place. If you just unload your player, you'll be fine.
Maybe to add also, Pete, give you a second question. If we would have a player with really no problems, and some of the London local clubs ask you to do some incuring, and you see some edema in the talus and distal tibia, what would be your workup? Would you unload him?
Well, what I would do is make sure not to take an MRI after 4 weeks, because everybody will do it, and it will be worse on the edema side, and the healing will already have set in. So that's the first thing I would do. But I'm just a believer of biology, and we give a bit of breath to the subchondral cancellous area, and that works for me. But obviously, meanwhile, I would make sure that the alignment and the stability is being addressed, because that's a secondary factor. Yeah,
I think so. That is important. So if the question was, if you find any edema, what will you do with that? You could also answer nothing. Because if there's a normal alignment, there's no ligament laxity, and you have a pro football player, then probably 6 out of 10 have edema in the talus and the distal tibia at the point. Because that's just, being a top athlete and being loaded all week. So there should be some extra symptoms, or there should be a malalignment or whatever to take into account that you're going to take measures for edema. But solely edema and not like a fluid line. A fluid line is different from edema. So digging into this question is quite an interesting question, because if there's a fluid line underneath the cartilage level, just between the cartilage and the subchondral bone, that is really a very aggressive tell sign that you have a potential delamination, and then you would have a full offloading. So there's a edema question. You can dig into this for a few hours, but
That's
a different webinar.
For cartilage problem, it's obviously significant. It helps us in defining situations. However, if you would take an MRI of a player just after the game, you will have edema like you've never seen that dissolves over the next couple of hours. So edema in itself is absolutely nothing to worry about, as Gino said.
So maybe this answer gives me to a question I have burning here on my paper as well. Back to cartilage. How soon after injury should clubs consider advanced imaging to detect or rule out any cartilage damage?
Okay. So yeah, different answers possible. So the first and second day is interesting, and then you have a repeat after 5 to 7 days. And then you would have your diagnosis there, because that would be the maximum elegant workup. So you have a trauma moment, and then you have a fast follow-up, both clinically as well as in an MRI after a week. So you can see if symptoms get worse also on MRI, and if they develop. So that would be the maximum diagnostic tool for me in the first week.
But what if you don't have immediate access to an MRI machine, which is not always everywhere possible for every ankle injury that pops up? Is there any more nuanced advice we can give to?
Yeah, I think so, Pete, on a physical exam.
So basically, swelling, deep pain, and mechanical complaints. That's a red flag that we have to address.
And that's an MRI.
And that's an MRI, I would say, yeah. And then obviously, we don't know if you can have normal cartilage in a good football player. So chondral defects, don't worry too much about it. Osteochondral defects are the ones you have to immediately attack. But it all depends on the size, the depth, the potential cystic deformities around it. So there's a bit more detail to it. But basically, look for osteochondral defects. And if that's the case, we need to know.
Okay, and if I quickly flip my question around, not as when should we take action, but what are the things we should avoid? What are the biggest pitfalls in early management that might even worsen long-term outcomes for cartilage injuries?
So not having the correct diagnosis and then sending the players out in the pitch. So the small example that I showed of the 7-year-old, that's a typical thing, Player wants to play. So I have physiotherapists and club says, well, we think you can play, and still has deep ankle pain. Pain on loading means that after the adrenaline, the pain goes down a little bit, but the first 10 minutes are really painful. Mechanical problem with range of motion. So dorsiflexion and loading is very painful, and the pain is situated deep in the ankle joint and not over the ligaments. That is something you should try and avoid, I would say, Pete.
Yeah, and sometimes the cartilage guides you to the problem. It tells you what's going on, whether it's malalignment. For example, last week we had a national team player with a cartilage that we treat for many months already, conservatively, very well, but it shows that there's a kind of hyperpressure there, where now, for example, there's a linear medial malleolar stress fracture that arises. So it sometimes is a sign that you just captured to understand what's going on and go back and say, okay, this is there, we manage it conservatively, but why is it there? And with that, it can teach you and work on prevention for other injuries. So it's not just the end stage, it's part of the whole spectrum.
Got it. So back to some questions in the chat. We gave people some opportunities to put some more questions in, but we're still moving a little bit away from the core topic we were talking about today. One question is on the knee, but the best treatment for cartilage injuries in the knee, and also how long does it take to heal in a female footballer? It is cartilage, so let's just talk about it. Who goes first?
Pete, what do you want?
Yeah, I'm happy to tackle it. Of course, again, cartilage injury in the knee, where Is it retropatellar? Is it medial condyle? Is it lateral condyle? Is it trochlear? So there's not one straightforward answer. The thing is that nowadays, if it's only chondropathy, so only the cartilage itself, scaffolds actually do very well. And whether we do it with augmentation, with some extra cells, obviously the biological scene is revolutionizing that area. But depending on the size, there are now good solutions, even on the loading areas of the knee. But it all depends on how big it is and then how you treat it afterwards. What we do is just put an environment in where you have as much potential healing as we, with the current knowledge we have, can give. But then it's about rehab. Don't underestimate that. There's a big rehab component to it, where accelerated rehab is possible, but has to be very detailed and well communicated. So there's a bit more to it than just an injury and a healing, whether it's male or female.
Yeah. I think to add that, actually it's quite the same with the ligament instability. So varus thrust or valgus thrust are not good to have. And then the alignment will guide you because if you have like a medial in a varus knee or a lateral in a valgus knee, which you can see quite often in the females, then it would be very helpful to unload the lateral compartment a little bit in your whole rehab strategy. So I think, again, also looking at the patient first and then alignment stability issues will also guide you in the knee a little bit there, especially in the early weeks after your surgical treatment will also help to see in which degrees of flexion the cartilage injury engages, and gets in a weight-bearing area. So I agree completely with what you already stated, Pete. Just some adds. Yeah.
And many female players, for example, also play volleyball on hard surface. So you have to consider also the extrinsic factors around that. It is really tailored to the sport specific, and like Gino said, the alignment and the size of the location of it.
Got it. But following up on that, because we're talking about recovery, rehabilitation, optimal outcomes, going back to the ankle and cartilage, right? So in your experience, is there any proper signs or what separates players who recover well from those who struggle in the long term?
Interesting question. Huh? It's a golden question. You got your golden card out.
Voila.
Yeah. So the most interesting would be to ask the question, if you say, okay, you have your not so simple sprain, and who progresses to develop an ankle cartilage problem anyways, so that will be the best one for the general population and all the football players. Considering that you asked the question, if you already have the problem, then I would state that a higher BMI, so the bigger players with the tougher bones, and then if there's already, let's say, a grade 2 or 3 osteoarthritis in the ankle joint with lots of osteophytes, diminishing of the joint line, some cysts, and then this one symptomatic bigger osteochondral problem, these would tend to give a bigger problem, because if you treat it, you get the ankle joint, you give an operation, so you lose some of the homeostasis. So the ankle joint has more problems to get from a catabolic to an anabolic status, which is much easier if you have a singular osteochondral defect, because then you have an initial inflammatory state, which is catabolic. You do a good surgery and you do a slow initial rehab, and you will get to an anabolic state, and the joint will heal itself. Whilst if you have grade 2 or 3 osteoarthritis already with osteophytes, you have to take away and some diminishing cartilage, and the rest of the joint will stay catabolic for a longer time. And it's much harder to get it into a nice anabolic state. So that would be like putting the ball on the penalty spot for Pete.
But basically you're saying here, Gino, that the more medical history you already have, the worse in the outcome of this one instance, isn't it? It's like a perfect storm for negative outcomes.
Yeah, zeker.
Yeah. Okay. But Pieter, the ball was on the penalty step for you.
I was hoping it was heading towards me, so I can just
All right.
a little bit and not. So, Evert, if I understand well, your question is: would Marco van Basten, if he would play today, would his outcome been better now with the current knowledge than so many years ago? And I would answer in two ways. I would boldly say yes. We probably can do better nowadays, especially for the larger cartilage defects, and the fact that we don't have to do bone marrow stimulation on them, or really we have better tools nowadays. But also I would not only be boldly, but also humbly say it would just probably be to extend a bit longer, where with the biological add-ons, with the current tools, we can extend it probably. But like Gino said, once you're in that cascade of grade 3 towards further degeneration, we can improve the pain, we can improve the function, but we can't really stop the evolution. And I think that's the ongoing challenge we all face.
Yeah. My next question would be, with what we know today, how much of this cartilage injury risk is actually preventable? Basically, what you're saying is it's not fully preventable, but we can manage it better than we did, by which we can extend, the onset of the real problematic issues. Got it.
So if we could do for a temporary partial offloading and slight distraction, that are the two proven mechanisms to save your cartilage and to get regeneration even of your cartilage. So that is our challenge, to come up with that within some years before I lose more hair, which needs to be fast. That's this.
But in all honesty, Gino, you've been like this for 20 years already, so you will not lose much more.
Thank you.
And there's one more question in the chat I like to post at you before I have a final question for you both. You, Gino, mentioned 2 treatments in your presentation, and then Pieter mentioned another one in his. But there is a bit of a confusion about that, what the indications are for each one. So maybe you can elaborate on that.
Okay. So I'll start, Pete. So for the topic would be either primary or secondary big lesions, so big cysts, so volume size over 20 square millimeters, over 15 at least. Because otherwise you could treat with BMS or augmented BMS. And for the LFF, it's just if it's fixable. So the golden card for treatment in fixable fragments, you should always fix. That is international consensus, also in athletes. So that will be the LFF as like a fixable plus. You add some cancellous bone.
Pieter?
Well, if we talk about the mesenchymal stem cells, let's say the orthobiologics injections, we all know that there's no straightforward indication that is evidence-based. However, if you have done a surgery and managed the alignment, the fill-up of the defect, and the stability, and you see a grade 2 to 3, after your surgery, it makes sense to me in our athletic cohort to give on a regular basis the first year, let's say every 3 months, an injection, just to keep the cascade as solid as we can, meaning that we can control the pain and the function. And some reports say that you actually stop a bit the evolution as well, but some don't. So that's the current evidence, and it's all low evidence. So we have to be humble as well. But in my kind of practice, first fix the problem, and then top it up with some orthobiologic injections in selective cases makes sense.
Clear answer, I guess. I have 2 more exit questions, one for Pieter and one for Gino, and I will just ask them to you randomly, and they're really practical. So Pieter, I'll start with you, if I may. If you had to name one thing clubs should do better the first 2 to 4 weeks post-injury, what would that be?
Don't use a cast.
Don't use what?
Don't use a cast. Plaster is disaster.
That's That's an easy one to remember. Okay, a very short answer. And then Gino, one for you as well. If you could redesign the standard return to play process, because they're quite conservative in football, with cartilage health in mind, what would you change, or what do we need to change?
I would make an injectable implant to partially offload the cartilage and to give slight distraction.
There we have it.
That would really help, you know.
With a UEFA grant.
Hey, nice one.
Hey. Yeah. Okay. No, thank you for these really short answers and practical as well. So also thank you for today. I think we filled the hour well, and your presentations were insightful and helpful to help us understand this problem way better. So I thank you for today, and see you soon. And then that brings us to the end of today's session, I think. Huge thank you to Gino and Pieter for the excellent insights, and to all of you for active questions and engagement. Not always on topic, but I think we try to answer them all. If you want to rewatch anything or share it with colleagues, this webinar will remain available on this medical YouTube channel. So please share the link. We will take a short break to allow for proper holiday celebrations, and we'll be back on January 5 with our next webinar, focusing on our newly published UEFA menstrual cycle tracking consensus. So we give a deeper insight into the recommendations we make and how you can use them on the pitch. And we're also hard at work on the upcoming injury prevention and rehabilitation guidelines for ACL injuries, a different topic. They will hit the pitch early 26. And given today's topic, we will also start development of similar guidelines on ankle injuries, helping you to navigate prevention and long-term management of ankle injuries as well. It's needed. Further, we're already planning the 2026 cycle. So if you have any ideas or topics or speakers you'd love to see, please send them to medical@uefa.ch. And we really love your input on that, so we can build a webinar series that's helpful for you. Thank you again for joining us. Have a great evening or morning or afternoon, wherever you are in the world, and see you in the new year.